Hello. Welcome to Anaphylaxis Management, More Than Just an Epi-Pen. My name is Nancy Nathenson. I'm a respiratory therapist. I'm a respiratory health educator and consultant, and also a community asthma and COPD expert for the Allergy and Asthma Network. It's my pleasure to be with you today. I am going to be presenting for the Salem Kaiser nurses on this recording here in Oregon. So I'm happy to be here. Thank you. So these are my disclosures. Our learning outcomes for today are to identify individuals at risk for anaphylaxis, recognize anaphylaxis symptoms and those that are a precursor to upper airway obstruction, explain the key components in the management of food allergies, and to describe anaphylaxis symptom progressions and the first line treatment. So, what is anaphylaxis? I'm kind of preaching to the choir here because nurses certainly know what anaphylaxis is, but bear with me. It is a sudden, severe, potentially fatal systemic reaction that can involve various areas of the body. In fact, it can involve almost nearly every single part of the body, and individuals' reactions are going to vary. They'll be much different from each other. So, what are the categories of anaphylaxis? Food allergies, insect, bee, and wasp stings, exercise induced anaphylaxis, latex, and medication. So, here is a list of anaphylaxis symptoms. It turns out that anaphylaxis occurs in about 1 in 50 individuals, but some actually believe it is much higher than that. Now, the skin involves itching, redness, and swelling, and this isn't always the case. The mouth, as far as itching and swelling of the lips, tongue, and a metallic taste, that actually is the precursor to upper airway obstruction when this type of response or manifestation occurs. And then, of course, there's the stomach and the lungs with wheezing or shortness of breath, coughing. The heart can be affected by a weak pulse or dizziness or fainting. And then all the rest of the list: headache, nasal congestion, watery eyes, sweating, confusion, all of those things, and even loss of consciousness. So, what patients are at risk? Anyone that has a prior history of anaphylaxis, asthma, food allergies, pollen and food allergies combined, and then also patients or parents that do not believe the above risk factors are a problem. Now, 20% I wanted to mention cases of anaphylaxis have no skin manifestations at all. It turns out children have a higher incidence of food related anaphylaxis, and adults for antibiotics, contrast media, anesthetic agents, and insect stings. So, is it anaphylaxis or is it asthma? Individuals with asthma are at greater risk for anaphylaxis. When you combine asthma with food allergies, it's sometimes very difficult to identify which is causing the problem, and confusion can cause a delay in treatment. Now, with a sudden onset of asthma symptoms, after food ingestion, use an Epi-Pen right away. So we have a case here, a 37-year-old male with a long history of allergic rhinitis and mild intermittent asthma. Develops an acute urticaria and shortness of breath 30 minutes after eating pecans. The patient was treated in the emergency room with an albuterol inhalation and 50 milligrams of Benadryl intramuscularly. Symptoms resolved within 90 minutes. Now, what would you think? Was this patient treated appropriately in your view? Yes or no? Well, the answer is no. And that is because this particular person was treated with albuterol and Benadryl, which isn't the proper treatment for anaphylaxis at this stage. And it took 90 minutes for it to resolve. So an Epi-Pen would have been appropriate. So it's, I think, important to wrap your head around what food allergies, the impact of food allergies and the statistics involved in our country, 1 in 12 children have food allergies. It costs about $25 billion per year to manage food allergies. And almost 30% of children with food allergies have asthma. That's a third nearly. And 25% of reactions are in school without a previous diagnosis. So here we have kids that we don't even know have food allergies that are having anaphylaxis and problems. 150 to 200 fatalities per year from food allergies alone, 40 fatalities from insect stings, 400 from drug allergies, and it turns out 1 to 6% of Americans have latex allergy. So, what is idiopathic anaphylaxis? When the cause of the reaction is not obvious or apparent, we're just not sure. So, when this happens, if there is a reaction and you're not sure, document the foods, medications, and any drinks that were ingested. Have a detailed list of the ingredients of those foods and the symptoms when they occurred. If this takes you to the ER, make sure the records come to your allergist. And if you see an allergist for the first time, sometimes those evaluations can take several visits because you have to have an in depth discussion and allergy testing as well. So, testing for idiopathic anaphylaxis, you would test for a variety of foods, skin tests, blood tests, underlying diseases that may mimic anaphylaxis. So, what are some of those underlying conditions that mimic anaphylaxis? And those are things like asthma exacerbations, panic attacks, vasovagal syncope. Um, uh, Vocal cord dysfunction, urticaria, and angioedema. All of these things can mimic anaphylaxis. Now, the treatment are if you would have 6 episodes like this for greater 6 episodes or greater in 1 year, you would have a daily treatment course of antihistamines or short course oral corticosteroids. If you would have less than 5 episodes per year, you would have no daily medications. However, in this category, it was going to depend on the individual and the previous reactions that they that manifested with them. So, food allergens. There are the top 8 food allergens are things like soy nuts, soy, fish, eggs, peanuts, tree nuts, wheat, dairy, and shellfish. Now, there is talk about sesame being possibly the 9th food allergen. And sesame is found in Middle Eastern and Indian and Asian cuisines. It is in hummus, in salad dressings, granola bars, hamburger buns, things of that nature. Now, there is such a thing as red meat allergy. Now, it is something that isn't a lifelong condition. Usually it resolves in a couple of years. It's triggered mostly by beef, pork, and lamb. It's also called alpha-gal. And alpha-gal that term is after the blood carbohydrate that's involved in red meat allergy. Now, itching and hives on the hands and feet are the most common. You could also have things like cramping, heartburn, diarrhea after eating these types of meats. Now, think of who would be at greater risk. Hunters and gardeners, of course, or would be at greater risk. And the red meat allergy is associated with tick bites. And with this allergy, you may have anaphylaxis on top of itching, hives, and cramping. Excuse me. Okay. Now, the diagnosis is with blood testing. And remember, I mentioned it's not a lifelong condition. So, how do we diagnose food allergies? We start with a diary, and you're going to hear this very often throughout, is documentation and a diary when we're trying to drill down and find out what's happening. Food allergy testing. We're going to do skin prick testing, and that's to help us identify stable or unstable proteins. blood testing for the IgE antibodies, and oral food challenge tests. That is the most accurate for diagnosing food allergies. Now, blood testing we would do, and that may be preferred for those that are at risk for serious reactions to skin pricks, anyone with skin problems, or medication interference. Oral food challenges should be done by an allergist in a facility where they have oxygen, epinephrine, IVs. There was a study in 2017 in the Annals of Allergy, Asthma, and Immunology, and they discovered that really only 2% of the individuals that have oral food challenges have severe reactions. Pardon me. So, what are the key points of allergy testing? No one size fits all. There are immune system changes, repeat testing when you move locations, when you develop new symptoms, or you are exposed to new allergens. So, managing food allergies, get out the diary, keep a diary. Allergy testing with skin, blood, or oral food challenges. But one of the most important things is to have a written allergy and asthma, or excuse me, allergy and anaphylaxis emergency plan. So, how do we conquer anxiety? And especially if we're thinking about as parents for our children, make a plan. If you're an adult and you've been through this for a while, you pretty much know the drill and you know the steps, and you have been able to possibly manage that anxiety that comes with food allergies. But with children, you want to definitely make a plan, investigate, and see what it is that's causing the problems and how things are being handled. Reassure and repeat to your child the importance of staying away from certain types of foods. Repeat that often. Reorienting them to the seriousness of it. Also, it's helpful to impart to your child maybe this quote where it says, "We carry our EpiPens everywhere, every day, and are prepared to use them right away." So, really enforcing that they should be with the child, they should be every single day, and they need to be used right away in a situation of anaphylaxis. You definitely want to keep calm around your child when it has to do with their food allergies, and think outside the box. Talk with teachers and other family members and things like that. In school, maybe there's alternatives to having snacks in school for celebrations. Also, seek help from professionals for you and for your child if you think you need it. That will just be helpful to manage and to cope with food allergies. It's a scary thing sending a kid off to school when they've got a food allergy. Also, empower your children. That's going to build their confidence. The more they know about it and understand it, the better that they will feel and more confident. So, how do we conquer anxiety? We start with the allergy and anaphylaxis emergency plan. And this plan is going to have listed on it the allergies of the individual, the symptoms that occur when a reaction occurs, emergency interventions that are used for this individual, how to administer the meds, so the directions on how to use EpiPen, etc., and who to contact. In addition, if the child has a higher chance of a severe reaction, it will identify whether or not the child can carry the medicine with them and if they can give the medicine to them themselves. However, if there is a child suffering from an anaphylactic reaction and they are approved to give it to themselves and they refuse, then an adult must intervene and give the medication. So here is an example of the allergy and anaphylaxis emergency plan from the American Academy of Pediatrics. It's easy to just go and download, and it has all of the things that I just mentioned previously on the previous slide. It turns out that kids bully each other for a number of different reasons, right? And food allergies definitely is one of them. It turns out 30% of children and teens report being bullied. Up to 50% of these children in ages grades rather 6 through 10. It harms children's social development and their self-esteem when they're bullied, no matter what they're bullied for. It's linked to underperformance in school, depression, and chronic stress. And not only are children verbally abused, but they can also uh, have intentional exposure by another classmate, where they actually intend to expose them to something they know they're allergic to. So bullying can go quite far and is very concerning. Now, the no bully zone. So it's good to talk. So when we're dealing with our children, we want to make sure we check in on lunchtime. Did good or bad things happen at school? Practice their responses. So, for example, maybe kids are saying, "Oh boy, I bet you wish you could have this ice cream or this peanut butter sandwich." And then the child's response could be, "Well, why would I want to eat something that's going to make me sick?" See the signs, observe. Many kids do not report bullying because they're embarrassed or they fear retaliation. And some do feel like they can just handle it, so they don't report it. It could be from reluctance or fear. And a child, you might notice that they have unexplained depression or anxiety. They might have changes in their sleep patterns or even weight loss. They may bring their lunchbox home from school full and have not participated in lunch because of that. What we do know is the research shows that when parents know a child is being bullied, the child's quality of life is better. So, does peanut free zones equal uncertainty? According to Matthew Greenhout, he says that peanut free policies may not be effective in preventing reactions. In 2008, there was a study at the University of Michigan, and nearly 20% of the reactions occurred in a nut free zone. Um, and so that's surprising. The residue of peanuts is easily cleaned up. Smelling peanut butter, you should know, does not cause allergic reactions, just the smell. Peanut dust does not become airborne, but it can accumulate on surfaces. And as I mentioned, it can be easily cleaned up. So, what we want to do in those peanut free zones is optimize those proven strategies of hand and mouth washing, no sharing of foods, and increase the awareness of children's restrictions in that zone. It turns out also that parents of children that do not have food allergies feel like the rules are unfair. So you may get some pushback on that. So, how do we avoid accidental exposure? According to Dr. Pistiner, the goal is obviously to prevent severe allergic reactions. So, and he also states that peanut free, this designation can actually decrease vigilance. So we want to be mindful of that. And any kind of training that's needed would be things like identifying reactions, being able to identify what's happening in a reaction, and the use of the Epi-Pen auto injectors for sure. Now, the challenges are preventing, things like cross contact. Preschool and kindergarten, it's kind of tough to manage those areas because children are messy when they eat and it's hard to keep track of, and they share their food and things of that nature. But older kids, when they're in cafeterias, we don't have such messy eating, and it's easy to implement those cleaning strategies. So just because it says that it's a peanut free zone does not necessarily mean that the proper management is in place. So in 2006, the Food Allergen Labeling and Consumer Protection Act came out. And this act stated that it actually mandated that the top 8 allergens need to be clearly stated if they are in the presence of food, of certain foods, of any food. Spice, food flavoring, coloring, processing containing the top 8 allergens must be identified. It does not apply to meat or poultry or some egg products. So that's not required in the labeling. And it's not required to list the highly refined peanut, tree, or soy oils in this on this label. So, what do we want to look for when we're reading a food label? And it's good to maybe engage your child, if they're the one with the food allergy, is into reading labels and understanding some of these key points. So, look for words like contains. Avoid foods that say may contain such and such, or produced in a facility that has such and such, manufactured on shared equipment with, so forth. Food manufacturers also, they can change their ingredients without notice. So you definitely need to keep on top of any kinds of changes that might not be overtly noticeable to you on that product. And if you're unsure, do not buy it. Check with the manufacturer. So, what's in a name? So, on the food label, you could see all these different names under these categories of food items. So, under dairy, you might see dairy may not be mentioned, but casein or curds or ghee or whey, maybe. For egg, it's albumin, meringue, peanut, legumes, nougat, sesame, tahini or simsim might be present on the label, but not sesame. Under soy, it's miso, tamari, tempeh. Wheat, you might see the words malt or spelt or gram flour. So that's why we have to be so diligent when we're understanding food allergies and reading labels. So, what do we do when we're dining out? You definitely should call the restaurant ahead of time. And now, like I mentioned before, adults have this down. They may call their restaurant ahead of time and they just know how to handle it. But what you can do if you have a child and you want to go out to eat, definitely do call the restaurant, create a reference card. So the card that states what your child is able to eat and not eat. Um, read menus beforehand and ask about the ingredients. I guarantee you the wait staff and the managers and the chefs, they all have had experience with managing serving food to individuals with allergies. So it's not going to be anything new to them. So cross contact. Cross contact is a situation when an allergen is in contact with safe foods. And when we have cross contact, we want to make sure, or when that is possible, we want to make sure we've washed our hands. We may have a separate shelf in the fridge so that any peanut items or shellfish items or something aren't intermixed with other food items that that individual that's allergic to peanuts or shellfish is going to be exposed to. Never share utensils, of course, or drinks. Avoid buffets and cafeterias because cross contact can definitely happen there so much more openly or often. And then you should know that when a kiss is not just a kiss. So it turns out that saliva holds allergens for up to hours after. And so we want to make sure that we're mindful of this should we have teens and so forth. So travel safe. What can we do? When we travel, we should call the airline or visit their website. Now, when you get to their website, you might look for something like a category called special travel needs. Sometimes airlines will also establish allergen free buffer zones, or they may even suspend serving peanuts and so forth. So after you've checked the website and so forth, when you get on the plane, inform the flight crew, wipe down trays and seats on your own if you're unsure. Bring something to cover your seat. Bring your own food is another good suggestion. And then carry your EpiPens on board. Do not put it in your checked luggage. And don't even put it on the overhead, in the overhead compartment. That just is wasting time or could very much delay treatment if you do that. So have it at the ready in your seat or near your seat. Print out the airline's published food allergy policy. That helps you if you get on board and they're not following it, you can point that out. So insect stings. Remember, I said something like 40 people actually die from getting stung by insects, and these are the culprits. The yellow jacket, those are the ones that hang around picnic areas and trash cans, and it's usually in late summer. They live underground in logs or walls. The paper wasp, those are kind of slimmer little critters than bees are, or hornets. When they fly with their legs like behind them. Their homes are under the eaves of structures, or in the trees, and they actually have a nest that looks like an upside down umbrella. Now, hornets are black with white generally or yellow stripes, and they live in trees and also under eaves of buildings. Now, the bees, bumble and honeybees, they're generally fat, dark brown, kind of fuzzy or hairy. They feast on flowers or clover. They're always kind of buzzing around there. They live in the ground or definitely near compost piles, or you might find them in your garden for sure. Fire ants. Fire ants, oh my gosh, in Florida, there were fire ants everywhere. They were terrible. They are red and black, and usually in the southern United States, they have these mounds that are dome shaped, like they can be 12 inches or 18 inches wide, and um, uh, and 12 inches tall. Now, definitely, if you see them, you might not see the ants, but if you step in it, you will be covered with ants. Not fun. So, what do you do if you get an insect sting? Flick the insect away from your skin. Just flick it off like this. Walk, do not run, and scrape the stinger off with a flat surface. Maybe there's a credit card, or you have a pocket knife with you, or something like that, a piece of cardboard. Put ice on it and expect redness and swelling locally, just right around the general sting area. Now you want to observe if that reaction goes from local to systemic. So if you have further rash or something on the arm, or streaks on the arm coming down from the bite site. So here is case 2. A 16-year-old male was stung by a bee and suffered acute urticaria, shortness of breath, and dizziness. After emergency room treatment with epinephrine, cortisone, and oxygen, he was given a prescription for a 2-pack epinephrine autoinjectors. So he has 2 epinephrine autoinjectors to take home. The patient's mom gave one to her son to carry and left one at school, kept one in her purse and one at home, thinking that if her son was stung, he'd be protected against fatal anaphylactic reaction. So they actually I misspoke, they got 4 total Epi-Pens, and this is how the mom spread them out. Is she right? Yes or no? She is not right. And that is because there are many cases that involve needing more than 1 Epi-Pen. So you should always have 2 Epi-Pens with you to treat any kind of reaction. Always 2. So venom immunotherapy. David Golden from Johns Hopkins, he says that venom immunotherapy can protect you from anaphylaxis 100%, and 85% of individuals can be cured of that allergy. So it will not bother them should they get bitten. First of all, the insect is identified, and the injections occur about every 8 to 20 weeks. And the person would have to remain in the office for about 20 to 30 minutes because they have to be monitored in case there are any severe reactions. No strenuous exercise can occur after the venom immunotherapy for several hours. Sometimes booster shots you get every 1 to 2 months. And within 5 years, it turns out you can have complete protection. But it's quite involved, and I definitely have no idea how insurance might cover this type of therapy. So the pollen food allergy syndrome, or PFAS for short, we'll call it. Individuals have PFAS if they have a history of symptoms consistent with PFAS. Those are the ones we find. If they have an allergic sensitization to pollen and an allergic sensitization to a plant food. So here is that combination then. And then when they have a known correlation between the plant food and the pollen. So pollen food allergy syndrome, PFAS, and OAS, oral allergy syndrome, um, and systemic reactions. Let's discuss that. It turns out that PFAS emphasizes that one may have not only oral OAS and PFAS symptoms, but systemic symptoms also, 2 to 10% of the time. Not a huge percentage, but still a concern. Usually, these types of reactions come only with raw foods. Cooked plant foods may provoke PFAS, but mostly it's raw foods. Prick by prick testing is used to fresh food is preferred for most fruits and vegetables. So they would prick by prick for fresh foods, not cooked foods. And stable allergens like peanut, hazelnut, and pea may be best detected with some commercial extracts are developed for the testing. So the take home message is that patients suspected of having PFAS or OAS plus systemic reactions should be referred to an allergist for confirmation, education, and to put this in context for them. So, oral food challenges. PFAS patients often have multiple positive prick tests to fruits and vegetables. However, the positive tests don't always predict that clinical symptoms will occur when they ingest those foods. The oral challenge is the only definitive way of diagnosing in this case. And then again, only by a board certified allergist should administer an oral food challenge. Never try this at home. Never give your child a little bit of something and see how they tolerate it and give them more and so forth. That's kind of a no brainer, right? So when do we do oral food challenges? When an individual has a systemic, right, a full body reaction to mixed foods, when the culprit food is not known, when there is a history of a reaction to a specific food, when they've had negative specific IgE testing, following any systemic reaction to determine the tolerance to cross-reactive foods that's not part of the usual diet. So they've had a reaction to something that's not even part of their usual diet. If it is unclear if cooking eliminates the symptoms, you might do an oral food challenge. And the history is also unclear, and the patient, if the history is unclear and the patient just wants to eat that food, doing an oral food challenge would be helpful in that case. So what are the fast facts of PFAS and OAS? The course is often benign. There's a small percentage that experience a serious reaction, which would be more like a systemic reaction. The severity of subsequent reactions is unpredictable. So you could have a serious reaction, then mild, and then serious again. So you cannot predict that. Severe reactions can occur upon the very first ingestion of a food that has cross-reactive allergens to it. And systemic reactions, any systemic reaction to previously tolerated foods can occur. Allergists are divided on the management strategy for PFAS and OAS. However, they have said, the NIAID guidelines have said that broadly interpreted, it would definitely allow for administration of an auto-injector. So regardless of how they want to maintain or treat PFAS and OAS on the daily, if there is a situation like an anaphylactic situation, an Epi-Pen is absolutely appropriate. So here is case 3. So case 3 involves a 15-year-old girl with a history of tree pollen allergy and develops itching of her mouth, soft palate, and ears each time she now eats apples, pears, and fresh vegetables. The reactions have worsened over the last 2 years, and recently now she has a dry cough when she's exposed to them. Would you prescribe an Epi-Pen auto-injector for this girl? Yes or no? Absolutely, you would. And that is just what I recently covered. Anytime now there is a new development and new symptom manifestations all of a sudden now, and they're increasingly getting worse. So not just from itching of her mouth and soft palate and ears and so forth, but coughing then. So that's affecting the respiratory system. So, what if you're allergic to exercise? There are some people that are allergic to exercise. What are the symptoms that might occur? Definitely extreme fatigue, more fatigue than you would think would be normal for that exercise or that activity. Wheezing, flushing of the face, a rash, shortness of breath, but also gut wrenching stomach pain, and also the need to use the bathroom. So, like for diarrhea. Now, if you suspect that your child or you yourself are allergic to exercise, seek an MD or board certified allergist for sure. So, exercise induced anaphylaxis, the course is really unknown, but they think there might be an association between eating food or taking medicine right before that exercise or that activity. So, the quick tips are have a prescription for 2 EpiPens and have them with you. Wait 4 to 6 hours after eating or taking any kind of medication. Have an anaphylaxis emergency plan. If the symptoms occur, stop right away, use the EpiPen, and maybe consider exercising with a friend that understands the situation and who knows how to deliver an EpiPen if you're unable. So, latex. Latex has been a problem, and it's many, many years ago. We kind of outlawed latex in hospitals and schools and things like that. It turns out that latex is an allergy to the proteins in a rubber tree plant. And the name of the plant is the Havia brasiliensis. And it is present in over 40,000 products that are made. The immune system responds to this harmless protein by overproducing IgE that leads to symptoms then. When sensitization occurs, you can have coughing, sneezing, watery eyes, and maybe even shortness of breath. So where in the world is latex? Oh my gosh, it's everywhere. Look, it's in our stethoscopes and in gloves, of course, in pacifiers and goggles and mouses for our computers and latex balloons, of course, zippers and things of that nature. So it really is everywhere. So or rather latex enters the immune system in multiple ways. So it can enter the immune system with inhaling allergens. So the powder that's in latex gloves, balloons, absorbing allergens externally via cuts or sores, and also absorbing allergens internally. And that can be via an injection port that you might have placed, stoppers on medication vials, and medication is drawn up through that stopper and it's on the needle. That can also occur. And so there's 3 different ways to enter the immune system for latex. Now, these are severe symptoms, and this is a 911 call. If you have feelings of impending doom or urticaria, so when you have urticaria, you know you've got a systemic reaction going on, shortness of breath, also wheezing, oral pharyngeal swelling, vomiting, and lightheadedness. If that occurs after being exposed to latex, that is like 911. Now, many are unsure of how the latex allergy has developed. And I mentioned before, 1 to 6% of the general population do have it, but 10 to 17% of healthcare workers in the US have it. 17% of restaurant workers. And most reactions to latex gloves are actually due to the chemicals inside. Contact dermatitis is one of the most common. Now, it also turns out that individuals that have multiple surgeries, like patients that have spina bifida and they have multiple surgeries, they are at increased risk for latex allergies because of all the different types of equipment that's used on them, IVs, ports, different things like that, surgeries, surgical equipment, etc. So how do we prevent it? Just strict avoidance if latex is a problem for you. So, what about medications? And what medications cause anaphylaxis? Antibiotics, penicillin is the most common. There are about 400 deaths per year, and it may not be a lifelong condition. So, it must be said that avoiding penicillin without an allergy diagnosis to it may not be the best idea. Other medications or other antibiotics that are broad spectrum can be less effective, and they can also be more costly, and they can have more side effects even. So keep that in mind. Aspirin and NSAIDs also can cause anaphylaxis. Anesthesia drugs, vaccines, especially egg based for some individuals, and insulin, although that rarely does occur. To have anaphylaxis from insulin. Now, the most severe reactions make sense that it would be from intramuscular or intravenous. So the symptoms of medication-related anaphylaxis: flushing and hives within moments to a few hours. Now, if that happens, that's not so much a 911 call. Contact your allergist. However, once you have multi-body parts, so you have those hives develop and you have wheezing develop and stomach cramps develop, then that would be a 911 call. So this is important to impart to you. The average time to respiratory or cardiac arrest due to anaphylaxis in food allergy is in just 30 minutes. This can occur. Cardiac or respiratory arrest. Venom allergy, 15 minutes only. And medication allergy, that could happen within 5 minutes if there's a severe allergic reaction. So there are many mediators in our bodies that cause anaphylactic symptoms. And you probably haven't seen these since you've been in school, right? Biology class or chemistry class or whatever. Leukotrienes, prostaglandins, kinins, platelet activating factor, interleukins, tumor necrosis factor. Wow, it's been a long time since we've heard that. And histamine. Now, antihistamines like Benadryl only target histamine of all of these mediators that are causing all of these symptoms, right? Antihistamines are going to maybe relieve the coughing, the sneezing, the watery eyes, maybe the itchy skin. But of the many mediators that are reduced during an allergic response, like you see here, histamine is just one, and antihistamines only target histamines. So here shows you the actions of epinephrine. And it inhibits the effects of all these mediators. So all of these mediators that are causing vasoconstriction, peripheral vascular resistance, insulin release, inotropy, chronotropy, things like inotropy, which is cardiac contraction, increasing cardiac contraction, and chronotropy is increasing heart rate, right? Then things like bronchodilation, vasodilation, all of these things are inhibited by epinephrine. So all of those things relax and go back to homeostasis or normalcy. So here is a graph that just shows epinephrine intramuscular time to onset. So you can see you have an event here, you peak, you give the medication, and within just less than 10 minutes, mostly within 5 minutes, the blood pressure, systolic and diastolic pressure have gone back to normal, and also the pulse rate has gone back to normal. So that's pretty much instant gratification from the epinephrine, right? So there are patterns or progressions of anaphylaxis that can occur in some individuals. Now, the uniphasic pattern of anaphylaxis is when symptoms resolve within minutes or hours after the treatment and they do not reoccur. Biphasic is when symptoms occur 1 to 72 hours after the initial resolution of symptoms. So the medication's been given, the symptoms are dealt with, and everything's back to normal. And then the whole anaphylactic reaction occurs again. This is biphasic. Protracted is in the event that symptoms continue for hours or days. Now, this is an individual that would most likely be hospitalized and have to be managed there. So here is just a graph that shows you you are symptomatic here, you get a treatment, you go back to baseline, hours pass, you become symptomatic again, you get the treatment, and you go then back to baseline. And that is biphasic. So the fast facts of anaphylaxis: the early signs and symptoms may not be outwardly apparent. Anaphylaxis can progress rapidly with death occurring in minutes. Epinephrine is rapid acting. It inhibits the effects of every single mediator, including histamine. Antihistamine does not act fast enough, and it only antagonizes the effects of histamine. Epinephrine is the first line treatment for anaphylaxis, and it is up to 30% of patients require more than one epinephrine autoinjector when there is an event. So approximately 70% of people only require one dose, but 30% do require two doses. Epinephrine is the absolute only medication that has no contraindication for anaphylaxis. So if you're unsure, just give the Epi-Pen. It's not going to hurt, even if it's not immediate. Even if it's not drastically needed in the case, if you're really concerned or worried. So no contraindication for epinephrine in this case. So two doses are readier than one. The episode severity and the duration isn't predictable, so we really don't know how a child would react one time versus another time to the same allergen. The episode may respond to initial treatment, but symptoms can return minutes or hours later, such as biphasic. And we also talked about the need for more than one dose in about 30% of people. So you see here the Epi-Pens, and then auto injector, and then the AviQ auto injector. So how do we use an Epi-Pen? You've probably all seen the Epi-Pen. You pull off that orange safety cap. You are going to firmly swing and push it into the outer thigh of whatever age individual you're treating, even if it's a child. You're going to hold it in place for 10 seconds, which means you're going to stabilize that individual if they're thrashing with the legs or crying or moving about, because you don't want that pen to come out, because some of the pens have a retractable needle, and so you cannot put it back in again. Also, you can massage the injection site. That's helpful for 10 seconds after, and then always seek emergency medical attention. And in schools, I'm sure you would have some type of a protocol for that. You're probably calling 911 in most of those cases. Now, there are side effects when you give the Epi-Pen auto-injector, and that is things like uncontrolled shaking or twitching, feelings of panic, and anxiety also. So this is what the person might experience after they get the epinephrine pen. So be mindful of that. How do we take care of our epinephrine auto-injectors? We need to store them at room temperature. Keeping them in a car is not a good idea. Extreme heat and cold can render that epinephrine auto-injector useless, ineffective, and also cause it to malfunction. So, for example, if it's outdoors and it's been freezing outside, it may be too cold to actually function properly. Things like direct sunlight and heat, oxidation occurs. And when that happens, the medication can have a dark or have heavy particles in it. Now, oxidation occurs over time. And so you want to, not just from heat, but just over time. So you want to check the expiration dates on all of your devices, wherever they are. Keep on top of that. Now, if your child has an event at school, the epinephrine pen has expired, you would just give it anyway. Don't hesitate to give it. Now, if it's discolored and dark and has heavy particles, it is likely not going to work. But if it's just seems fine, it's just outdated, in an emergency, you would go ahead and give it. This is the AviQ auto injector, and it's nice because it functions with voice commands, and it's like an automated external defibrillator or an AED, right? It just walks you right through it. And so what you do with the auto injector AviQ is you remove the red cap here, and then you firmly push it into the outer thigh of the individual, and it is going to tell you hold in place for 5 seconds, and it will count down those 5 seconds and then say injection complete. So it's going to walk you right through it, and that's very, very helpful. It turns out all 50 states guarantee the right to carry and self-administer epinephrine as long as they have been cleared for that. So older children can carry it and self-administer. Most states allow or require schools to stock EpiPens. Now, I don't know that that is the case for Salem Kaiser yet. I believe you guys are investigating having a stock epinephrine program in your schools. And so that is, there are steps to doing that, and there's guidelines for that. And I'll tell you about that in just a minute. So this is a nice resource, and this is from the Allergy and Asthma Network. So don't hesitate to go to allergy asthmanetwork.org and just, get the benefit of all of their resources. This is one on epinephrine treatments. And so it shows you all the different types of auto injectors. It tells you if they're voice command, it tells you if they have a retractable needle, those types of things. It also at the bottom will tell you about resources where you can get help with payment. There was a time, some of you may remember, when Epi-Pens were $600. My goodness, how could anyone, afford that? But the AviQ, which is the Kaleo company, it has offered free auto injectors, and many of these places that you see at the bottom of this poster here have resources that can help. There's also publications from the Allergy and Asthma Network, Allergy and Anaphylaxis and Understanding Anaphylaxis. I have the Understanding Anaphylaxis magazines that I'll be supplying to your nurse leader to distribute, so that you can have at least some of them available as a resource. They're great, and they're written in lay terms and have really good information. Here is the anaphylaxis at a glance poster, which this is really nice to be posted, maybe in a classroom with a child that has epinephrine or has food allergies or anaphylaxis. I also have a lot of these too, so I'm going to give a little stack to you too. Stock epinephrine in schools. This is where you go. There's two links here. One on top is going to help you with stock epinephrine planning and the steps needed and what you need to do to get that going in your school. And then the other is just on planning for school with food allergies. So please research the Allergy and Asthma Network resources. So there's some myth busters about food allergies. And one of them is that children younger than 3 years old cannot be tested for food allergies. Well, the truth is that there's no specific age limit for food allergy testing in children. If you think your child has a food allergy, then contact an allergist and they will evaluate your child with history, with their symptoms, and recommend options for testing. The next myth is children with an egg allergy should not get the flu shot. The truth is that children with mild reactions to eggs, such as hives, may receive the regular flu shot. The CDC recommends that they be monitored in a physician's or a pharmacist's office for about 30 minutes after receiving the injection, just in case, because they would have the Epi-Pen there if needed. Gluten is a food allergen, and eliminating it from my diet will help me feel better. The truth is, gluten is not a food allergen. It is a protein composite that we find in wheat and barley. It's in rye. It's also and the GI problems that come from gluten, what's happening is you're experiencing a food intolerance. It's not an allergy. And the GI problems from gluten are things like bloating, gas, things of, stomach cramping, things like that. So the next myth, I experience only a mild itchiness when wearing latex gloves, so I am not seriously allergic. The truth is that many individuals with latex allergies experience only a hand rash when they're wearing latex gloves, but this can be a progressive condition. And so reactions to latex can become more severe with repeated exposure. So please keep that in mind. Also, the last myth I believe here is I am allergic to shellfish. Since shellfish contains iodine, that must mean I'm allergic to iodine-based surgical scrubs, radio contrast solutions used for x-rays, and CT scans. Iodine in this case is not an allergen like gluten. It is present in our bodies, in our thyroid hormones, in our amino acids. It's essential to our health. There's no cross-reactivity with iodine-based preps or radio contrast. So here is a list of your resource organizations for you to access and get good information. You can get the allergy and anaphylaxis emergency plans. Here's more references for your information. I want to thank you for your attention today, and feel free to reach out. I live in Oregon City, Oregon, so I'm here for you if you need anything. And if you need any supplies, also let your nurse leader know, and she can contact me, and I will see that you get what you need. I have lots of supplies available. Thanks again. I appreciate you guys. Have a good day.